Hey guys, welcome to our next session. Our moderator is Ezekiel Oburu, coming to us from Kenya, and he is going to talk to the panelists and moderate a session on Cavo Varus foot and ankle deformity. You guys are in for a treat with a fantastic faculty. Ezekiel, it's all yours.
Thanks very much, Selene. Thanks. Greeting everyone from Nairobi, Kenya. Thanks, Selene, for organizing this wonderful meeting, really quite an event in itself. We have speakers from all over the world, and our topic of discussion is going to be Cavo Varus foot. This varies from place to place. Certainly in my country, Kenya, we see quite a bit of Cavo Varus feet, and we have an opportunity to operate on a number of them. But if you look at the literature, sometimes there is no set algorithm or set way of how an orthopedic surgeon or a foot and ankle surgeon should tackle these deformities. And therefore, we've got an excellent panel of at least 3 speakers now. Alan Young from the United States. We have Altug Tanriover from Turkey. And we have Sundararajan Ramasamy from India, Ganga Hospital in India. So I'll pass this over to Sundararajan to start us off.
Okay, good evening from India. I think I should thank Dr. Selene for having me here. And also, I want to acknowledge him because basically I'm an arthroscopic surgeon, became foot and ankle surgeon because of Selene after visiting Duke University almost 12 years before. And also I'm taking part in his all Indo-US foot and ankle courses, which he conducts at least twice in a year. And also I thank him for updating and spreading the knowledge of foot and ankle in India. And because of him, and we are here. And also I want to thank Dr. Raju Shah for mentoring me in India. So herewith I start with, I am having 2 cases with the 2 different scenario. This is a case of a 60 years old diabetic female patient. She developed progressive deformity of left foot for 10 years duration. She says she had trauma in her adolescence age, and after that she couldn't remember what happened after that. But for these 10 years, because of the progression of the deformity, she was treated with the braces. She had a couple of plasters with the local bone setters, which is very common in India. And she didn't have any relief. At present, she complains of pain while walking. And also she has recurrent instability while walking in unstable areas. I mean, she also has got the deformities over here. You can see when she is standing, there is an exaggerated medial arch, and also you can see that forefoot is adducted, and hind foot is very much in varus when you see from behind, and also the front view shows that lot of cavus and the varus of the adduction of the forefoot. And this is the lateral view when you see from the side, and so it's very obvious and shortened midfoot. And we did a Coleman block test. It can shows that correction of the hind foot that shows that it is a forefoot driven cavus foot, and that's you can see that there is some types of, that means it's not a subtalar driven cavus foot, and that is her walking. And from the front, it is obvious she has got a lot of cavus and varus, and you can see from the behind, it is very obvious she has got a lot of heel varus too, along with the cavus and the adduction of the forefoot. That is the range of movements what she has got. She has got only around maybe from 20 to 40 degrees of plantar flexion. There's no dorsiflexion even in passive, and there is no active dorsiflexion too. And that is the subtalar movements which he has got through passively with some movements. That means the joint is not very bad, but there is no active movements. And tibial is posterior, was 5x5, and she had a mild clawing of the toes. There no dorsiflexion of the ankle, and there is dorsiflexion of the toes were present. She didn't have any sensory deficit too. When you see the X-rays, she had got, you can see that the right side is the normal side, the left side is the adducted side. And you can see the lateral view on standing, that is the normal side, this is the affected side. You can see the Mary's angle over here, and you can see there is a lot of first drop of the first metatarsal. There's a shortened midfoot. You can see maybe the old injury, because of that the talus is how much shortened compared to the normal side, and also there is some changes over the talonavicular joint, degenerative changes. You got a lot of tenderness over the talonavicular joint and also first MTP joint. And when you see the angle over here, which I saw, you see that Mary's angle, this is the first metatarsal, and you can see the talus angle. There is so much drop over there. The calcaneal pitch angle shows so much widening of the calcaneal pitch that shows the cavus foot. And you can see that Saltzman view that shows the lot of varus, and the AP of ankle shows normal joint. And you can see that the bony deformity of the calcaneum because of the chronic and long-standing deformities. So problems were pain, deformity for 10 years. She has got an unstable gait and failed conservative treatment in hospital, and foot is not braceable too. So basically she had a cavus foot, adduction of the foot, first metatarsal drop with the degenerative changes, and also there is a degenerative changes in the chopper's joint and severe heel varus. So options, there is a possibility that can be done by Elizero correction, which I am not expertise in that. So I plan to do an open corrective osteotomy and fixation. The only question was to start from where, because it's a forefoot driven cavus foot, so I thought of from doing the correction from distal to proximal. The only question is to do only a medial column fusion or the extended medial column fusion, because he had already some degenerative changes over the talonavicular joint. So the fusion was on the cards because of the degenerative changes. And also the heel varus, the question was to do a deep displacement osteotomy, lateral displacement osteotomy, or do a device osteotomies like that, and also to do a tendon transfer or not. So here we started with the medial extended incision to do the plantar release. At the same time, we had done the plantar release, then we did an osteotomy of the first tarsometatarsal joint to correct the metatarsal drop. Even after doing the correction, the cavus could not be corrected, and also she had a wear and tear of the some talonavicular joints. We thought then do a dorsal wedge osteotomy on the talonavicular joint. So I did an extended medial column fusion. Then he did a medial displacement, lateral displacement calcaneal osteotomy in the calcaneum to correct the heel varus. At the beforehand, and even we did the tibialis tendon was harvested. So tibialis posterior tendon was harvested, and it was splitted into two, and it was brought into the position after doing all the osteotomy of the midfoot and the first tarsometatarsal joint, and fixed with the screws and the K-wire, and displacement osteotomy was fixed with the screws, and the split tendon was sutured into the tibialis anterior and the peroneus. This is the final picture of the osteotomy, and fixed with the screws over there. That is the lateral view of that picture. That was the AP and axial view of that same picture. And we can see correction of the forefoot adduction was very much in the cards. And in the lateral view, if you see that normal pre-op and the post-op, and we could correct that first metatarsal drop into the almost into the normal position. You can see the Mary's angle is into neutral, and also the calcaneal pitch has reduced very much. So we could correct that cavus also as much as we can. And this was only 1.5 months old. I'm waiting for the further follow-up, but we can see that very good correction of the foot. Because of the multiple incision, the wound healing was delayed. It took almost 3 weeks to heal very well. This is the 4 weeks follow-up. And you can see the wire I have not removed. We are going to remove it after 3 weeks time. But the foot is, there is no cavus over here, and the forefoot adduction was completely corrected, and the heel varus is corrected. To conclude, the forefoot driven Cavo Varus deformity correction is you can try to salvage the joints if there is not much arthritic changes. But here, because of the long-standing and degenerative changes, and also 60 years old diabetic patient decided to do a fusion, and also the patient required an aggressive varus correction, and also do a tendon transfer for dynamic balance. Now coming to the second case, I finish it faster. This is a 42 years old male patient presented with the pain and non-healing ulcer over the lateral border of the right foot for 4 years duration. She had a neglected CTEV and also operated 20 years before, for which is some soft tissue procedures. Then patient started developing wound over the lateral border of the right foot, and they treated conservatively for the last 1 year. You can see the deformity, severe Cavo Varus deformity, and you can see the ulcer over the lateral border of the foot. It was not healing because he was walking only on the lateral border of the foot. You can see that is a walking videos. It's a 44 years old patient. It's a very severe deformity, and this is how he walks. It's not abrasible also. It is almost fixed joint, so there is no movements at all. When you see an X-ray, then you understand that the patient had developed already. You can see that a lot of osteophytes and arthritic changes on the calcaneocupoid joint, and also there is a talonavicular joint. And you can see that the APV2. And you can see here carefully, the ankle joint is completely subluxed over here. You can see the lot of space. So the patient developed, because of this severe varus deformity and the long-standing issue, unfortunately, the ankle joint also damaged a lot. And also there is a damage on the charcot joint. So you can see that already there are stress fractures over the 5th metatarsal. Here it is seen very clearly over there. It's always very challenging here to correct this deformity. Of course, you can see that already because the patient developed arthritic, it's a very painful foot. It is very difficult to salvage this condition here. You can see the varus of the heel over here in the Saltzman view. So here problem is a pain, non-healing ulcers, unstable gait, and not working for 1 year. On examination, he has got TA tightness, for which release was done. He had a heel varus, Cavo Varus midfoot with arthritis of midfoot and also subtalar joints. And also there is an ankle subluxation with the secondary arthritic changes. So here are options whether you're going to have osteotomy and Elisero correction and soft releases. It's possible. But because of the arthritic changes, I tried to do a correction by open and fuse the joint. We got done a TA lengthening by percutaneous stenotomy. We did a lateral displacement osteotomy for a calcaneal for the varus. But because of the damage in the subtalar joint and ankle is subluxed, I couldn't salvage both ankle and subtalar. We don't have any ankle replacement here. So I did a DTC fusion with the screws and also midfoot osteotomy to correct the cavus and adduction, and did a medial column fusion. So that is the displacement osteotomy. In the axial view, probably I would have corrected a little bit more in the varus. That is a forefoot adduction was corrected by doing the midfoot osteotomy. So extended fusion was done here. We included the patellar up to the middle column. Of course, it is going to it made him very stiff ankle, but at least now it's braceable and he is walking on the braces. To conclude, the long-standing neglected CTVs are very challenging to treat, especially after developing arthritic changes. It is not just the deformity, and also the problems are secondary arthritis. So joint sparing is difficult and may need fusions if the person very late. Thank you very much.
Thank you very much. Just 1 or 2 questions that I wanted to ask, especially your first case. You said you did a split tibialis posterior tendon transfer. Now, how effective is the strength of the tendon when you split it? Does it provide any dynamic strength, or it just acts like a tenodesis?
Yeah, I think most often it acts as a tenodesis because it's a long-standing equinus deformity. But he's got a reasonable ankle movement, but very stiffness was there. We know that only the toe dorsiflex are working. There is no ankle dorsiflector. So at least by doing a tibial tendon transfer, we can prevent the foot drop so that it at least hold the foot in slightly in a plantigrade position. So mostly it acts as a tenodesis, as you said, absolutely correct.
Yeah, and also the other question that I wanted to ask is, how often do you start from the anterior aspects of the foot? How often do you start from the front, in the sense you're starting from a dorsiflexion osteotomy of the first metatarsal, as opposed to many who would, start with probably a medial release or a tibialis posterior, transfer? How often do you start from that and work your way to the back?
So because this case, I thought because it's a 4-foot driven Cavo Varus, because of the severe metatarsal drop, I started from the distal to proximal. So I thought of doing cavus correction only on the first tarsometatarsal joint. But even after doing the correction, there was some cavus in the midfoot too. At the same time, as you saw in that X-ray, there is already shortened midfoot, so there is no way we can do any osteotomy in the normal midfoot bones. So, and also there was evidence of some arthritic changes because it's a 10 years duration, it's a 60 years patient. So I just extended that I did an osteotomy in the dorsal base, but not a big one here, basically because I could correct most of the cavus through the first tarsometatarsal joint, but I did a small wedge and fused the talanavicular joint in this case. But not often I don't do an extended medial column fusion like this.
Okay, thank you very much. I think we'll proceed to the next speaker, who is going to be Alan Yan.
Okay, all right, let me share my screen. Okay, hold on. Sorry. Do you see my screen?
No.
Oh, okay.
Yes.
Hold on. So sorry. Here it is.
Yes.
Yeah, we can see it now.
Okay, great. All right. Well, this is a great pleasure to be a panelist on this very interesting topic. And thank you very much for Selene allowing me to be a part of this exciting event. I've been feeling excited ever since I learned that I will be a panelist. And I still remember the days when I was at Duke. I learned a great deal from Selene, from his practicing style, efficiency, and also inspired by his international leadership, as it shows today again. So let's get back to the topic we're going to talk about. And I'm going to share, I'd like to share with some thought process and the learning process that I learned from afraid of this type of deformity to enjoy the satisfaction after the correction and patient satisfactory when they're coming back to the clinic. So Cavo Varus foot and understanding of a CMT cases. I have this young kid, he's not a kid, it was a 32-year-old gentleman coming back to me, and he has a bilateral Cavo Varus deformity due to a known diagnosis of CMT. So Sundara has a great documentation of all the cases from the beginning to the end. I have somewhat a good documentation of the key points. And there was a very interesting point that patient has 2 million followers on TikTok, and he shows every step of his recovery. And I didn't know it until like very late in the recovery process. So my thoughts is I either going to be famous or infamous, and depending on how I do. So so I'm thinking about the goal of the surgery of any deformity correction. I try to get back to this. So I would need to have, the patient need to have a tripod foot so they can be a plantar graded balanced position, and if they can work with a brace. Usually a grapple type of a brace for those type of patients, that will be a success. And then if it looks good, and the patient need to be feel good, so they do not have the pain they have before. So, and also if I can achieve no further perpetuation of deformity forces and less chances for the recurrence. And for CMT, it's a progressive process. And sometimes, you know, you are not, I do not know how to make sure the patient has been stabilized. But, you know, usually in adults, when they're coming back to you, the deformity you have, it is what it is. So this is the patient, and how I figure out share my process, how I figure out from the deformity to the correction, and the lessons that I learned. And there are many ways to correct this, but there are a flow through thoughts like how to analyze from the beginning to later execution of the surgical plan. So this is what the patient looked like. So he is a pretty typical family history of autosomal dominant type of a CMT presentation. And his father is wheelchair bounded and never had any surgery done. And he also has a bilateral hand intrinsic muscle atrophy And this guy has a pain and weakness and deformity, which is tried many times with braces. And at the time, this is the first time he decided to do surgery, and he's already 32 years old. So that's the standing position, and he is not able to ambulate without a pain or without reasonable balance. Now, the lesson that I learned from those type of deformity. So we all talk about the standing X-rays from the hip down to the knee to the foot and ankle. Now, this is the time that I learned a new lesson. So that could trick you. So you look at the X-ray full leg length, you might think this guy has a valgus knee deformity. So however, because of rigidity of the foot and ankle deformity, so when he stands, so he has to accommodate to that rigidity. So, but then you're looking at the physical exam, you straight out this guy's knee, the knee is actually in neutral alignment. So this is like a very good lesson that I learned from this case. So physical exam is really, really important. I think that take precedence to the X-ray imagings, and also we mentioned about CT, MRI, and EMG, whether those are really needed or not. So X-rays, all planes of the X-rays we get are from AP lateral and hindfoot alignment view. Anyway, those I use this as a confirmation of the information I already got from the clinical examination. Because the CMT, fortunately, there is a pattern that probably we can follow. So now, the key information I distilled from my clinical surgical plan from physical examination. So overall, this is a non-plantigrade foot, and it's rigid. So the 2020 FAI had AOFS did a great job in a consensus meeting. And that is really the best, one of the best papers summarize the CMT management. I recommend that everybody can have a chance to take a look. So now from this patient, the forefoot, he has a claw hallux and claw lesser toes and a forefoot valgus. This is what is expected. And that formulating my plan is later how I'm going to correct this. So the midfoot, I look at the X-ray, looking from the patient. He has a cavus high arch, supination, and metatarsal plant, first metatarsal plantar flex position, which is it's quite typical for the tendon imbalance from those patients. So overpowering the peroneus longus and weak to peroneus brevis, and also overpowering of the PTT is very common. So in the long term, those patients have contracture of the medial structures, which you have to release in order to correct the deformity. So, and also this guy has adductor inversion, also due to the overpowering and the chronically contracture of the soft tissue on the medial side extensively. Now, the hindfoot varus heel, and also the rotation, you can appreciate it when you're taking the lateral X-ray. The fibular position is way posterior than normally you can see. So the ankle is an important part to take a look at it, whether the ankle is involved or whether you're going to do anything. So there is presumed instability of the ankle. However, when it's standing still, this guy's ankle, the mortise looks fine. And the clinical test is important to see whether. So still the orthopedic principles for a medial side and a lateral side, when you do any deformity, if it's in varus, the release the tightness and strengthen the loose part. So that apply to all the deformity correction. Now, the lower leg, tibia, femur, and knee and hip, is there anything contribution from there? So the first lesson that I learned, which is, teaches me a lot from this. So what else do I need for the surgery? So do we really need a CT scan? So I did get a CT scan for these cases. So because that, in my mind, that helps me to decide if I get lucky, if all those joints, like the CC joint or TN joint or a subtalar joint is arthritic, then it's no brainer. I'm gonna fix those. I'm gonna fuse this. So even if I do osteotomy, that may not resolve the pain he's gonna have. So the other one is MRI, whether it's really needed or whatnot. I didn't get it from this patient, and I didn't get an EMG. This guy has already has a genetic test positive diagnosed the CMT patient. From the consensus letter, there's no consensus. It's optional for a CT and an MRI. Now, genetic test, of course, when you get to the orthopods, and genetic test is really, it's not routinely needed, and case study is also not routinely needed. So the latest reference, as I mentioned, this is a great paper, concise and follow through. I hope I already saw this patient before I do many cases fumbling through. But anyway, it's, after that, and I read this paper, that make a lot of sense to me. Now, consensus change is a key question here. Is the deformity fixed or flexible? That's the key question we always ask before. That what I was taught. So a Coleman block test is kind of like it may tell you. So whether it's a flex or flexible, fixed or flexible. However, the term has been changed from that consensus meeting. So they from a pre-op assessment, it turns out to be a intra-op assessment is more accurate. So whether it's a reducible, partially reducible, or irreducible, even after you release all the stuff you want to release, the medial side, and still irreducible and not plantigrade, probably at this point you need to consider a fusion. Now, information gathered before surgery is same confirmed as from the literature and also from my physical examination. So, now it's time that for me to make a decision. Is this a soft tissue only procedure, or it's going to be a bony procedure or a combo? So I think that from my understanding, either soft tissue only or bone only is hard to correct as moderate to severe deformity. So it's probably, even if you need to do a fusion, the patient could have a type of instability and you cannot last very long. So you still need a soft tissue corrections on top of it. Now, the Coleman block test, is it really overstated? So only by Coleman block state can you make a final decision. I probably, it is, the answer is negative, but that gives you good information, whether the patient has a forefoot driven hindfoot varus. But in that kind of 3D type of complicated deformity, you only correct the forefoot. I don't think it's feasible for those type of patients. So strategy, how would I start with? So what I've learned from the cases that I have done is do not burn your bridges. That means you have to thought through which one you got to do first. I made some mistake because this guy has a bilateral deformity. I changed the low-hanging fruit. I started with the side which is a little bit less severe. So this side, later I will show you and what mistake I kind of make. But I fortunately I can salvage it with a PTT transfer later, because I resected, I lengthened the PTT in the first stage. I staged those surgery. So talk to the deformities, kind of like you see the deformity as it's unfold when you do the surgery step by step, of which one do first, which one next. It's kind of it makes sense. Now, foresee the problems and difficulties for those type of patients, especially for the second, the opposite side of the foot. I did in like 4 or 5 months, and I did have wound issues, and I did a couple of things which I finally salvaged it, and that learned a lot of lessons from there. So do I do a chronic gradual correction or acutely or a combination? This one I choose to do a combo, so it's not in the literature. A lot of so there are cases reported people only doing Elizarov to correct the Cavo Varus foot, or you do open acutely shortening or acutely multiple corrections for osteotomy or fusion. Now, this one I choose because I foresee that kind of difficulties of the wound healing, and the medial side is extremely tight. If I lengthen it acutely, or if I need to shorten it, that might be a lot of surgery. So, and the medial side wound will be a concern. And it'll make my surgery probably prolonged and difficult. So first I did a Achilles lengthening. So the Achilles lengthening is also sometimes it's a little bit controversial. So some of our surgeons choose to make it an intra-op decision. So this one I did open Z lengthening and put the frame on and released all the medial tight tissues with the capsules and tendons. And I did make a mistake. It included, I almost resected PTT. So I housed myself for a later on transfer. But what I did is a above ankle level triple cut lengthening. But later on, unfortunately, I can still use that tendon for transfer. So Now, the other one is soft tissues. So what is the role of the plantar fascia release? And besides all the other things we have mentioned. So, and how are you going to do it? Is that only plantar fascia? Is that all the way, or is that like just enough? And when you do the intraoperative, I do not think there is a clear answer. People are doing different things. The PTT transfer, I did do it at the second stage, and I used it. And sometimes you can use a variation of bi-dose procedure for balancing your tendon transfer. And this is very cool, and it's good to show your resident what you can do. And now the thing is, I've learned those patients with long-term deformity, their bone quality is not as good. So the tenodesis screw sometimes pull through. I have a patient that tenodesis screw pulled through and migrated out. So so for tenodesis, and then the posterior tibial tendon, you can transfer to the cuneiform or to the cuboid even, or to the peroneus brevis. Actually, what I find right now is to tenodesis to the other tendon is probably more reliable than using hardware to fix those due to the bone quality. Now, bony procedure, osteotomy or fusion. Constantly, you assess the heel position with a procedure progress. It's a simple LDCO, multiplanar dorsal displacement, whether you need to do it, or foreseeable consequences, whether you need to fuse it. Those are all the questions you need to be considered. And also, a little bit of detail is LDCO. I find it's much harder to do than MDCO. MDCO right now, I pretty much do a minimal invasive. However, I'm not able to do it minimal invasive for the LDCO. So I still open it, and sometimes I have to shorten it and cut it or wedge out and totally release it. I learned from my friend from Midwest, I did it a couple of times this way. It works for me. So when to fuse it, and we try not to fuse it in young guys. However, if we're not able to correct a varus and DJD, some muscle function is too poor, or a bony deformity. So apex of the deformity, midfoot deformity, there are ways to correct it in severe cases, though. So I have not ventured into that realm yet. I'd like to see what other panelists experiences on that. I'm a little bit, concerned for healing. Now, what else? So we have formulated on my plane for the forefoot correction. So I did first metatarsal dorsiflexion osteotomy, many ways to deal with it, and later, if we had time, we can discuss it. And the Jones procedure, I did it, and I learned a painful way how to do it efficiently. Jones procedure, because to drill, you drill from A to P. If I started with a very lateral, or even in the middle, it's hard to retrieve from the medial side. So later on, I directed it in the easier position to make it easier, and also straight it out. This is what it looks like. So the other side, this is the other side, the second foot, I have a hard time to close the wound after everything is corrected. External looking is very good. I have to using the pike crusting, and this is the stage correction, a la carte correction of this. Details is important, and I remember this says, Mike Tyson says, everybody has a plane until they get a punch in the face, and that's what I've learned from those surgery. And have a great fun, and thank you very much.
Hey, Zeke,
thanks,
I'm going to ask a couple of questions, because there are a few questions here before we fall too behind on questions, if you don't mind.
No problem.
Dr. Sundar, comment on the use of the filoplace or tibial nail for TTC fusions in like the second case that you showed that was so severe.
Yeah, I mean, I would love to do a TTC fusion. Most often I use the TTC fusion in my all my series, but in this case, really, I'm not sure why I've changed to only screws over here for the stability purpose, but it has went on to the heel very well. But I often use only TTC nailing, most often.
TTC nail is preferred, okay. And then the second question for you, Dr. Sundar, is how would you approach a horizontally oriented talus, which is commonly seen in the Cavo Varus foot correction? And basically, how are you reducing the ankle dorsiflexion stop that could happen if it remains horizontal?
I think it's essential to do the soft tissue release, enough leaves to release the spring ligament and the posterior medial release to get back to the that almost like a rocker bottom talus in most often. Before you do that, even after doing these, all the soft tissue releases, Then if it is not coming into the position, then you do the osteotomy. But I think soft tissue releases are very important here.
All right. And then Alan, this is for you. Any tip in planning the posterior tib transfer when it's too short to transfer to the cuneiform or cuboid?
Right, that is a real problems. Like I didn't expect it in the very beginning, even if I thought I did very distally. So the distal insertion is actually not only to the the process of the navicular, also extended a little bit plantarly to the cuneiform. So I get as long as I can. Now the other thing is when you transfer to the interosseous membrane, I try to open up the interosseous membrane as big as I can bluntly, so it has some room to wiggle. And then when I tension it, so do whatever I can. If I'm not able to pull it through in the bone, and then I transfer it to the perineus brevis. So in that case, the length doesn't matter that much.
Great.
Good. I think, Selene, I think we'll proceed to Altug because of time.
Yep. Thank you all. I'm really very happy to be a member of this wonderful family. I had once chance to visit Dr. Selene Parekh in Duke and have had chance to see his wonderful surgeries. Now I'll try to share my screen. But first of all, I guess Dr. Jan has to stop it.
He has to stop the screen.
Oh, sorry.
Yeah.
Okay. I guess it's there. You see my slides, right? Okay. Okay, I'll be pretty much speaking like Dr. Yan as about Cavo Varus deformity. Most of all, Charcot-Marie-Tooth or neurogenic deformities, more bony deformities like post-traumatic disease, post-traumatic deformities, which I love playing with. Unfortunately, in my country, we still see post-polios and neurologic deformities, and unfortunately, again, Charcot-Marie-Tooth is pretty common. I have no disclosures. I'm also a confounding member of Balkan Foot and Ankle Society, which hopefully you'll be hearing more about in the future. Starting my talk, I'll be talking about deformity assessment. As Dr. Jan has perfectly cleared the things out, the most important thing is if it is, to me, rigid or flexible, starting from hind foot to forefoot. And if it's a rigid hind foot, you can do it hind foot calcosteotomy, subtalar joint procedures. And if you have your forefoot rigidity, you can start with first ray osteotomy, where we used to say if it's forefoot driven or hind foot driven, which I find calling it rigid or less rigid or semi-flexible more convenient to use in terms. And if you have a bone joint deformities, as it's a post-traumatic disease or something, you will have more complex midfoot osteotomies, which I don't like doing, most of stiffness and lots of things to do. And quite often you end up, as Dr. Jan's talk was also so, you see lots of, in your cave stalls, you see lots of osteotomy illustrations. Unfortunately, not so much intraoperative things, because in a midfoot osteotomy, you don't often end up with perfectly done wedges. So as my talk will be much on semi-flexible Cavo Varus deformities caused by neurologic deformities like Charcot-Marie-Tooth, I'll be talking about tendons. Talking about pathophysiology, what causes the Cavo Varus deformity? There are weak muscles. There are peroneus brevis and intrinsic extensors, and strong ones, which even further increase the deformity, which you have to assess when you're deciding. I think for a neurologic patient, especially in pediatric patients, which I do operate a lot, you have to assess tendons, muscles, neurologic compromises truly and a truly understanding of which is working, which is strong, which is weak, which is contracted a lot, and you'll end up with a cavus deformity, which is possibly the first metatarsal plantar flexion and calcaneus varus secondarily, probably. So Coleman block test, as Dr. Jan again said, is a good one to do, but it's not always easy to understand perfectly where it's driven from, but it gives you an idea where the deformity comes from, which is very important to assess subtalar joint flexibility. And looking at the soft tissue procedures, I always start with releases, like plantar fascia release. Gastrosoleus release is usually a part of the, mostly the part of the surgeries. We'll use strike-out, straight, whatever we want. And one of the most decision-making issues is stability of tibio-talar joint, which I'll be talking about. If you have your tripod good enough, and if your tibio-talar joint is stable and it's well aligned, I don't think the amount of cavus is that much important for the outcome, because you'll end up with a stable and a good aligned tibio-talar joint. Probably the patient will be happy. I'll talk to that later in my cases. And you will do lots of tendon transfers, especially for your neurologic cases, which you transfer mostly the tibialis posterior, sometimes tibialis anterior to the lateral side if you have metatarsus adductus, and peroneus longus is usually the strongest one to plantar flex first ray, which you can transfer to peroneus brevis. Also, for accompanying cloving, you can use EHL, EDL, and you can use FHL for dorsiflexion sometimes. So looking at the Cavo Varus cases, our Charcot-Marie Tooth cases, I have lots of questions. As I said, how much cavus is cavus? Do you always have to address cavus deformity as long as you have a pretty good tibio-talar joint? That's one of the concerns. And why do we operate if you have a plant grade but food which is stable without calluses? And what will your criteria for a successful reconstruction will be? Thinking about Cavo Varus deformity, I always get into mind comparing it with progressive collapsing foot disease or adult acquired flat foot. As you know, flat foot has a very well-defined algorithm, not a perfect classification, but has modifiers to the deformities. Looking at the Cavo Varus deformity, do we have a real good classification? I don't think we don't have. So we have perfect algorithms, but we have to tailor our surgery to each and every patient, each Charcot-Marie tooth or each post-polio patient, as it's is unique, and you have to assess each and all tendons, deforming forces, and joints and bones, alignments, and stabilities and flexibilities. So a perfect algorithm will be understanding of each case and tailoring your treatment. So that's what we do. I'll state two cases. These are my cases which I have presented years ago. These are both Charcot-Marie tooth cases. First one is a 40 years old male. It's a bilateral case, and he has plantar ulcers to his first metatarsal head. For a long-standing ulcer, he is severe equinus, and he has cloving to all toes and slightly metatarsus adductus, slight cavus, but slight varus, but high arch disease. And looking at his neurologic examination, he has a tight Achilles, tibialis posterior seems contracted and strong. and tibialis anterior is 5 or 5, and peroneus brevis is a little bit weak, but peroneus longus is pretty fine. As I said, he has slight calcaneal varus, but the examination reveals a little bit mobility to subtalar joint and reveals a little bit mobility in midfoot. And cloving is semi-flexible. You cannot reduce it perfectly, but it's flexible a little bit, which encourages me to not to do midfoot osteotomies or so much extensive surgery. So looking at his X-rays, as the metatarsus adductus is there, you do not see tibio-talar joint perfectly, but you can see how cavus he has. And due to the cloving, you don't see the fingers pretty well aligned. They're all almost dislocated MP joints, but they're all clothed. So what to do? What I did was, this is worth discussing, I think, because many of the orthopedic surgeons would be so keen on doing midfoot osteotomies and also fusions even. But what I did was, I did a gastrocnemius recession, plantar fascia release, and I did EHL to metatarsal head Jones procedure, which I like very much. About even with diabetic patients with the plantar ulcers, it works well. And what I did was I did all long extensors to metatarsals transfer, Jones to all metatarsus, as the last case of Dr. Jans, and I did 5 toes IP arthrodesis and peroneus longus to brevis transfer. This is intraoperative. I usually do, when I'm doing my Jones transfers or the other ones, I do Z lengthening, Z incisions to decrease wound pressure. And I like putting these guide wires temporarily for a couple of weeks to keep the fingers in place postoperatively. This is what I did. And this is the early post of X-rays. As you may see, it's still pretty much cavus, but I believe it will get well in. This is 6 months post-op. He's pretty plantigrade, without ulcers, all healed, and did well. It works. So if you have a pretty plantigrade and a good tibio-talar stable joint, possibly playing with your tendons will allow you to have a good, happy patient. I did the same for the other side of this patient. This is the case. Looking at my second case, pretty much the same, but it's more severe deformity.
Hey, Altug, before you do that, I've got some questions that are coming in for you. Can we hit those before you do your second case?
Okay.
So for the lesser metatarsal, do you just do a closing wedge osteotomy, or do you do any rotational correction through the midfoot?
Oh, I didn't do any osteotomies.
No, not for this one, but in general, they're asking.
Generally asking, if it's not flexible, I do closing wedge osteotomies, always.
As the whole panelist agrees? Federico?
Without, I don't understand, without any rotational correction?
They're asking if there's a rotational deformity, are you just doing a dorsal closing wedge osteotomy, or are you also adding a rotational correction through the midfoot?
For me, for this case,
no, in general, not for this case. In general, if in your practice, it may happen to add a rotational correction, and how you do this rotational correction and how you assess that your rotational correction is properly done. This is a question. It's not a just pointing on this case.
Oh, okay.
Yeah, so just a general question. So what do you guys do? When do you decide dorsal closing wedge osteotomy to the midfoot, and when do you decide a rotational correction to the midfoot?
If you ask me, if the cavus is so hard, so high, you have to do a closing wedge. But always, and metatarsus adductus and supination pronation deformity coexist. So as you're doing a midfoot osteotomy, you have to correct pronation, supination, rotation also. What I love doing is percutaneous with Gigleso, percutaneous osteotomy, and rotational correction that wise.
And then this is for all the panelists as well. If you choose to fuse a Cavo Varus foot, either because of severe deformity or degeneration, do you also recommend doing soft tissue procedures such as transfers with the fusions, or are you just doing fusions alone? And maybe if all of you guys can comment on that, start with Federico, and then work our way through.
If there's
sorry, you go first. You go first. You go first.
If there's a deforming force, deforming tendon or neurologic problem, I always add tendon transfers because it decreases your recurrence and it helps you balance your foot and gait.
I totally agree with this idea, because also we have to consider the role of the ankle. I think that every time you have an in-foot Cavo Varus deformity, it may have an influence on the ankle. So you need to reduce the deforming force in order to have a balance correction. And so I agree with Altug.
But Zeke?
Yeah.
And Sundar, and then Alan.
Remove the deforming force because the tendons and the muscles are what's driving the deformity, then obviously you're going to have a recurrence. Almost you're starting from a very bad position.
Sundar?
Yeah, most often all the neurological cases where you have the deforming force, I do the tendon transfers. Unless sometimes it's a traumatic cases where you have a deformity, where you have a good neurology, then I don't do.
And Alan?
Yeah, I do, because not only correct the deformity, it also prevent future recurrence. So you need a balance.
Cool. All right, we got 5 minutes left. Zeke, whatever you want to, or actually,
yeah, I don't know. Maybe Federico, do you have anything to say?
Yep.
Sorry, we've run out of time because.
No. I had a technical problem. I was not able to jump in at the proper moment. So I think it's more interesting to stay on the discussion, I think. So I have, because we don't have time to have a complete presentation. So my question for everybody is, do you consider always plane correction again, or do you consider rotational correction during your Cavo Varus foot procedure? And my question, because this is something extremely difficult for myself to assess, is when you plan a rotational correction, which one are your reference point during the surgery? How you decided that you are doing enough? You try to overcorrect, or you reduce your correction? You don't go in overcorrection.
Anyone to answer that?
I haven't been fortunate enough to do any overcorrection in any Varus case yet. But for metatarsal pronation, you may be right. It's difficult to decide. Starting from the hind foot, if you go to forefoot, probably you'll be better doing rotational deformity assessment.
Thank you. I think it's interesting. And so now I have another question, the last one, I swear. When you correct a Cavo Varus foot, your idea is, in general, not in terms of rotation, to do a slightly overcorrection, or just to achieve a plantigrade foot, but not overcorrected? What is your goal?
Yeah, most often I think if you try to get even plantigrade foot is more than sufficient, because it's most often what we see is more deformed, chronic, neglected cases. So if you can get a plantigrade foot, I'm more happy. So I don't do any overcorrection.
Thank you.
All right. I got two quick questions before we have to wrap up. One is, and maybe you say yes or no, do you regularly recommend EMG muscle testing for all your Cavo Varus foot cases before surgery, or do you just do muscle testing by clinical evaluation? Alan?
I'm mostly relying on clinical evaluation.
Altug?
Agree, Alan. Agree.
Zeke.
Clinical.
Sundar.
Clinical.
Clinical.
Clinical. Okay. Last question. How do you do the midfoot tendon transfers when you're doing a midfoot osteotomy? Anybody?
Can you repeat? How do you do?
How can you do the midfoot tendon transfers when you're also doing a midfoot osteotomy?
Through a buttonhole.
I drop it on the midfoot osteotomy.
Drop it on the midfoot.
Interference screw, I prefer small interference screw.
Yeah. Sundar, do you guys have interference screws?
Yeah, we have.
Yep, we do.
I do interference screws. I go from anterior to posterior and do the interference screw.
Okay. Excellent. Well, thanks, team. You know, Cavo Varus foot is, to me, the opposite of, obviously it's the opposite deformity of flat foot, but similar in the sense that there are no set algorithms. Everybody kind of figures out their own algorithms based on their own experience. And it leaves a lot of surgeons with a lot of angst. And there seems to be more angst on Cavo Varus than there is on pes planus. So thanks for sharing some of your experiences and getting into some of your concepts about it. I appreciate your time, and we will be back in a few moments.
Thanks.
Thank you.
Thanks, everyone.
Thank you, Selene.
Thank you.
Thank you.
Thank you.
Thank you.